Good afternoon for those joining us from the East Coast. Good morning for those joining us from the West Coast. My name is Cyril Adam. Welcome to Adolescent SBIRT in Schools of Health Professions with Virtual Patients. Today's webinar presentation. We're very happy to have you. I'm just going to go through a few housekeeping items before handing it over to our presenters. So before we get started, just know that this presentation will be recorded. You will be sent a copy of the recording after the presentation is over. For the duration of the webinar, you will be in listen-only mode, but you can feel free to submit questions on the right side of your screen, and we'll have a Q&A at the end of the presentation when we can answer them. And please connect with us, follow us on Twitter at Kognito. We look forward to seeing you there and to engaging with you. Kognito is a health simulation company based in New York City. We develop role-play simulations that enable organizations to rapidly build the capacity of health professionals, consumers, caregivers, individuals, and so on, to lead real-life conversations that improve social, emotional, and physical health. As you will see, our approach combines the science of learning, the art of conversation, and the power of gaming technology. Here on your screen, you'll be able to see the interface from SBI with Adolescents, which is a simulation we'll talk more about during this webinar presentation. This is a snapshot of a simulation that we've developed to help train health professionals to conduct screening and brief intervention with adolescents for substance use. The way the simulation works is that you get to interact with 3 virtual adolescents that you can see on your screen, Emily, Josh, and Kayla. And you will be able to engage in a conversation with them by using the conversation menu, using the talk button that will allow you to decide what to say and to receive feedback both from the virtual patient or client to whom you are speaking, as well as from a virtual coach who will give you feedback on your motivational interviewing skills and how well you managed this conversation, and whether you did it in a collaborative style or whether you did it in a kind of pushy or judgmental way. So as you'll see, you'll play the role of this virtual health professional, which can be a nurse or a social worker, and you'll be able to interact with these 3 virtual patients, not only to develop your competency to navigate these conversations, but also to assess your skills. And as you'll see in the presentation, this assessment component has been kind of a central part of the project that we'll talk about. So without further ado, let me introduce today's panel. Our first presenter will be Laurel Hitchcock. Laurel is an associate professor at the University of Alabama at Birmingham, Department of Social Work, and will be speaking about the evaluation and the results of the implementation of curriculum and simulation in her programs. Next, we'll have Tracy McPherson, who is a senior research scientist at NORC at the University of Chicago, a large independent research and evaluation organization, as well as Hildy Cohen, who is a research director also at NORC at the University of Chicago. So without further ado, let me hand it over to our presenters. Enjoy this presentation.
So thank you, Cyril. I think this is Laurel Hitchcock, and I think I've got objectives. So if we could move to the next slide, please. So real quickly, what we hope to do today is talk to you about 3 things. And one is just to learn about the Adolescent SBIRT curriculum and online training program that you saw a little bit about, developed by Kognito. We also hope to give you some ideas of how educators, whether you're in higher education or working with continuing education units in your facilities, how you can incorporate this training into a process for learning about adolescent SBIRT. And then also, we'd like to share some key learning outcomes that we've discovered from pre- and post-test measures with this particular training. So if we could move on to the next slide and just talk a little bit about why SBIRT, why we chose this particular model. We know, first of all, that SBIRT is simple, it's brief, and it's effective. There's considerable evidence to demonstrate its effectiveness, and with adults, we also know that there's a growing body of evidence to indicate that SBIRT is also very effective as a prevention and early identification approach to reducing the use of substances by youth, particularly underage drinking and cannabis use. Moreover, we know that there are numerous medical professional associations and government agencies that have endorsed SBIRT for youth. This includes the National Institutes of Health, SAMHSA, the Health Resources and Services Administration, as well as the Agency for Healthcare Research and Quality. We also see this being endorsed with international programs, such as I'm looking on my list here. Numerous medical professional associations and international programs, such as the American Medical Association, the American Academy of Pediatrics. We also know that there's some evidence to suggest that SBIRT could be mandated through certain statutes. SBIRT is part of a continuum of substance abuse care that is deemed an essential service required as part of health care plans under the Patient Protection and Affordable Care Act legislation. And we also see it as coming under the early periodic screening, diagnosis, and treatment statutes at all states required for Medicaid-eligible children. Additionally, from a social work perspective, we know that using SBIRT really addresses one of the social work grand challenges, which is to ensure healthy development for all youth. And finally, one of the things that I see particularly at my institution is that including SBIRT really helps to promote interprofessional education. This is a practice that is used across different professions, and by bringing our students together, it's an opportunity for interprofessional education on our particular campus. So with that, I'm going to turn it over to Hildy for the next slide.
Great. Thank you, Laurel. So I am going to give a very brief overview of the SBIRT model, and then I will give you a brief overview of our project, which works to create an adolescent SBIRT curriculum for implementation in schools of nursing and social work. So first, the overview of the SBIRT model. Here you can see that there are several aims of SBIRT with youth. And the first one is to increase early identification of adolescents and young adults at risk for substance use problems. The SBIRT model also aims to build awareness and educate adolescents and young adults on the U.S. guidelines for low-risk drinking and the risks associated with substance use. Third, SBIRT aims to motivate those at risk to reduce unhealthy, risky use and adopt health-promoting behavior and seek help. And then finally, the SBIRT model aims to link adolescents and young adults at high risk to more intensive treatment services and to foster a continuum of care by integrating prevention, intervention, and treatment services. Next slide. So just to make sure that we are all using the same definition today when we talk about SBIRT, we use SAMHSA's definition, which notes that SBIRT is a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk of developing these disorders. Through SBIRT, practitioners work to identify substance use that increases the risk of physical, emotional health problems, disease, and injury, in school, work, family, or social life. And SBIRT helps to reduce the impact of these issues. SBIRT can be effectively and efficiently integrated into a range of entry points and settings that are not substance use specific. So some of these settings include primary and behavioral health care settings, hospital emergency departments, criminal and juvenile justice settings, dental clinics, HIV clinics, as well as military and many other settings. You can go to the next slide. Thank you. So there are 3 core components of SBIRT. First, screening, which is used to quickly assess degrees of risk. Next, brief intervention, which takes the form of a short clinical encounter using motivational interviewing. And for those with higher risk, a referral to treatment and linking to care. So our grand challenge in this work is how to train students and current practitioners to effectively apply SBIRT with youth. There has been a lot of work done in this field with adults, but our project is devoted to developing resources to train the future workforce to work with adolescents specifically. So a brief overview of our project. In September 2014, with a grant from the Conrad and Hilton Foundation, we launched the Adolescent SBIRT project with over 30 subject matter experts and associations coming together to create an adolescent SBIRT curriculum and 4 implementation tracks for schools of social work and nursing. A learning collaborative was also created with over 280 social work and nursing educators, field instructors, preceptors, practitioners, and others that have joined to date. As part of the Learning Collaborative, we provide a monthly newsletter for all members and hold monthly meetings where at least one member shares their experience implementing the Adolescent SBIRT curriculum. And in fact, we have our December Learning Collaborative meeting at 3 p.m. Eastern today. And we are scheduled to meet through the spring of 2018. So if you're interested in joining, there is a link on our website, sbirt.webs.com/join us, and you can get on our list. It's free to anyone who would like to join. You can see here that this will look familiar, the picture of the SBI with Adolescent simulation that Cyril presented at the beginning of this webinar. The simulation is a component of the Adolescent SBIRT curriculum. I won't go over the simulation in detail since Cyril introduced it, but that is a piece of the curriculum. And then the instructor's toolkit also includes a learner's guide with a companion slide deck that faculty and trainers can use to design their lessons. The guide features 1 module for each phase of the SBIRT technique and a full module on motivational interviewing. There are suggested readings for each module. The guide includes resources such as screening tools, pocket guides, role plays, and performance feedback and evaluation tools. You can order an electronic copy at no cost on our website. That's listed below at sbirt.webs.com/curriculum. We also have, as part of the toolkit, a number of other resources to help implement the training in your program. These include IRB materials, course syllabi, sample homework assignments, and pre and post evaluation measures. You can advance to the next slide. And our website, again, sbirt.webs.com, under our resources tab, includes a number of resources. Here are just some screenshots of some of the materials that you can download for free off of our website. And now I will turn it over to Tracy McPherson to talk about the pre and post test measures that we have created for the evaluation component of the project.
Thank you, Hildy, and thank you, Laurel. One of the pieces of the toolkit that we've been able to develop with our steering committee and our members of our learning collaborative are evaluation measures, and it's really important, I think, for when you develop education and training materials in whatever form that you do that you evaluate those. And one of the things we try to do in particular with this project is to kind of come together and bring folks in the field together to talk about what are the measures that we're using to look at learner outcomes. Do we change attitudes towards working with individuals who use alcohol or working with adolescents, competence and confidence and readiness in being able to utilize screening and brief intervention and various elements of that. And so what I'm going to do is kind of walk you through a couple of the measures at a high level of what we have been using in our evaluations. So next slide. The first measure that we're using is a measure of attitudes. These are notoriously funny little tools that you have to deal with. They don't always demonstrate change over time and in a short period of time. Attitudes are often difficult to change. They're just one of those things that we struggle a little bit with when we're talking about interventions, whether it's interventions in learning or other types of interventions. The other thing that I think as evaluators that kind of challenges us is that many of the measures that we are familiar with were developed a long time ago, and the language they use is stigmatizing, it's not person-centered, often has outdated language. So one of the things that we took on was working with our steering committee to really look at measures and try to identify what, to the best of our ability, might make a good measure of attitudes in terms of working with individuals who may have an alcohol or drug dependence disorder, attitudes about addiction and alcoholism, again, terms that have sort of been moving sort of differently in this space over time. And we also tried to work with them to change the language to be more person-centered. And as in a process of doing this, we ended up identifying a 7-item measure. We're doing psychometric analysis on these measures. And this will look familiar to you because they're based on the BSAS, which is a much older, longer measure. What we hope is that we can help you utilize a more brief measure in evaluating your own programs. So we're doing that psychometric testing, and we have actually done a poster on all the tools I'm going to be talking about. So if you're interested in that, I can share that. But this is the 7-item measure that we're currently using. And again, it's one of those tools that I'll show you has been notoriously unpredictable in terms of measuring change. Let's move to the next tool that we are utilizing. This measure is a measure of competence, and this is a measure that really looks at perceptions of one's own competence in terms of conducting elements of screening, brief intervention, and referral, in particular using some motivational interviewing skills. So the learner actually rates their own perceptions of their competence about asking adolescents about alcohol and drug use, very specific around utilizing a standardized screening instrument to screen, looking at their competence in assessing adolescents' readiness. And this is just a sample of the 17 items that we are utilizing. Interestingly enough, and again, you can see this on, if you would like a copy of the poster presentation we recently did on our psychometrics, this scale actually hung together as one scale. So we have done various factor analysis on our various tools, exploratory and confirmatory factor analysis, and we are replicating our psychometric analysis over time. And so far, we're kind of demonstrating the same thing. So what I hope we'll be able to do is not only see how it performs in evaluating the learner's outcomes in implementing the simulation training and the toolkit materials, but it'll also help you as you evaluate your own programs utilizing these materials. If you could advance to the next slide. This is a measure that we're using to assess confidence, and these are the 9 items. These were developed in collaboration with the steering committee, really trying to reflect on what are the things in the learning that we're trying to build confidence around. And again, these are confidence, perceptions of competence in terms of their ability to perform very specific elements of screening, brief intervention, referral, and motivational interviewing skills. So you can see, if you were to think about breaking down, whether you're breaking down the BNI or frames or any other model, flow, whatever, there's very specific kinds of elements and skills that go into a brief intervention. And that's what this measure is trying to get at, is one's confidence in being able to perform that. You know, we may see confidence in one's ability to administer, you know, a craft adolescent screening tool, but we may not see confidence on providing feedback to an adolescent or talking about decreasing risk with adolescents. So what we're trying to get at is really confidence around specific skills, but we're also trying to say is, does this kind of measure hang together? How does it perform over time? These are the 9 items that emerged in this one factor solution. Again, we're utilizing and replicating this in our evaluations over time, and Laura will be talking about her findings. She's also been using these measures. Can you advance to the next slide for me? Thank you. So the last measure I wanted to share with you is around readiness. So readiness is really about one's sense of preparedness and readiness to actually screen and intervene. And we used these 4 particular items, which did hang together in terms of being having more internal consistency. So we have been utilizing these as well, replicating these over time. But what you'll notice is that we did break these out. Some of the readiness measures we've seen used in the past asked about how ready are you to screen adolescents for alcohol use, illicit drug use, prescription drug use, depression. They kind of put everything into one item. What we tried to do is, without burdening the learner with too many items, is separate alcohol out from illicit drug use and prescription drug misuse. So you'll see we have readiness to screen and readiness in terms of conducting brief interventions for these different substances. And again, this one hung together. It has continued to kind of perform this way in our replication of the evaluation. So I'm hopeful this is another contribution to you all, what you all be able to use. And I would really be interested, if you all are using these or are doing something similar, is sharing what you have been using with us. And hopefully together we can create tools that can help evaluate our programs. If you advance to the next slide. I'm going to turn it over to Laurel so she can talk about her program at the University of Alabama at Birmingham.
Great. Thank you, Tracy, and thank you, Hildy. Just real quickly to let you know about our institution, and I'll talk then a little bit about how we implemented this training and curriculum into our program. We're a very large urban campus located in Birmingham, Alabama. We have a very large Bachelor of Social Work program, over 250 students, and we also have a brand new Masters of Social Work program just starting this very semester, and we've enrolled our first 37 students in that program, so we're very excited about that. Along with our social work programs, we have a large medical school, a school of nursing, which is actually one of the top 10 in the United States. We also have numerous other related schools such as optometry, dentistry, allied health professions that has physical therapy, occupational therapy. So we are really a medical campus. And we started working with the Hilton Project back in the spring semester of 2016. We first participated in a pilot program where all we did was implement the SBIRT training that Kognito produced with our students. So they did a pre-test, they did the simulation training, and then they did a post-test. Following that semester, we have since that time implemented the program along with the curriculum. So what we do now is our students take a pre-test at the beginning of the semester, which includes all those measures that Tracy talked about. We then do a short lecture about SBIRT with adolescents in the classroom, and then our students complete the online simulation training at their leisure, sometime during the semester, and then we follow it up with the post-test. Excuse me. So if we could move to the next slide. So I'm just going to share some initial analyses of our data collected from the fall 2016 semester. And the reason we're sharing this semester is because this is the one where we implemented the curriculum along with the simulation. So we had 44 students actually complete the pre and post test. We implemented this training into 3 different courses throughout the semester. One in our Social Work Practice 1 course, an elective course on medical and mental health, and then we asked our field practicum students, those who were already out practicing in the communities, to participate. So while we had an actual total of 77 students complete the training, only 44 completed the pre and post survey, giving us a response rate of about 57. And what you'll see here is most of our students were female, most of them were white, and we did have a few non-majors take this training as well. And on average, our students scored an 80 on the training, which according to Kognito, 80 is a passing score with that training. So moving on to the next slide, just to show you what our outcomes were. Again, we saw significant changes in attitudes, perceived competence, and readiness. If you'll see on that first line there, we saw a significant change in attitudes. So we saw an increase in willingness for our students to work with adolescents who use drugs and alcohol, and our students had a better attitude towards looking at drug use or alcohol use as a treatable illness. You'll see there on the second line, perceived competence. Our students had increased feelings of their own competence to work with adolescents who use drugs and alcohol. On the third line there, competence, we didn't have any significant outcomes there, but you do see a trend towards more confidence in their abilities to work with adolescents who use drugs and alcohol. Again, not statistically significant, but we saw a slight increase in those pre and post mean scores. And then finally, readiness. You'll see that our students reported an increase in their readiness to work with adolescents who use drugs and alcohol. So overall, positive trends based on 1 semester's worth of data and working with our students. So I think we can move on to the next slide, and I think Tracy's taking over here.
Yes, thank you, Laurel. Yeah, so what I'm going to share with you is an evaluation of one of our tracks. And this track we fondly call Track C, and we have descriptions of these tracks on our website, and we talk about these in various places if you visit our website and look at our materials. This Track C program was really designed to engage nursing and social work programs who wanted to implement the instructor toolkit and curriculum and the Kognito simulation in whatever way they wanted to. So we worked with them to design their implementation and to kind of fit it into where in their course it made the most sense. So given that, this particular track and this particular analysis focuses on 9 schools who implemented during the spring semester of this year. Now, keep in mind, all 9 schools have a slightly different implementation, but the goal was to really touch on all of the modules: screening, brief intervention, referral to treatment, and motivational interviewing at some level, and that really was determined by the program and what was appropriate, and then to integrate the simulation wherever in that process made the most sense for them. And the 9 schools worked with us to implement the same pre-test evaluation survey, which was the sample measures that Hildy mentioned earlier that are available to you, and to replicate the use of that survey and to do a post-survey administration. Most often, it was implemented at the beginning of the semester and then again at the end of the semester, and then the education was delivered in whichever way they designed their plan. So that's sort of the frame of this particular Track C implementation and evaluation. In these particular schools, and we did have more schools in this track than 9, but these at this time when we did the analysis actually had collected their post-test data and had complete pre- and post-test data. So we'll be doing additional analysis with other schools. But what we can share with you is in this particular analysis, we had a sizable sample of students in nursing and social work and interprofessional students. And these are students that could be in nursing or social work, but there is also potentially counseling, other mental health practitioners, who could even be other areas of medicine. And the courses were designed to be interprofessional instead of strictly nursing or strictly social work. And more than half of these students were graduate students. It was about a split of undergraduate to graduate. And we had a high level of engagement in completing the online simulation training with the students. Next slide. So what I want to share with you, you remember what Laurel just shared with you about what she observed in her evaluation. What's different was we did not actually observe a change in attitudes. It's pretty flat. The interesting thing is that it already starts pretty high. So on a scale of 1 to 5, you're already starting out about 4.2. There is room for some change and improvement, clearly, but they're starting out fairly favorable overall anyway, and there's not much change in this particular sample. It's different from another track that we actually did observe a change in attitudes towards working with adolescents who use substances. And I believe in that particular sample, we actually started off, the baseline was lower. So I know that because it's one of those measures I mentioned, gives us some challenges. The other finding, if we think about competence, and again, this is perceptions of one's competence to deliver specific elements of screening and brief intervention and motivational interviewing skills, utilization of that with adolescents, we demonstrated improvement in competence, the perceptions of competence over time, and that that was clearly something that it's one of those things that we're hoping to demonstrate, that perception, but one of the things that we also want to demonstrate with this is actual competence, right? So we are doing an analysis of skills, the ability to demonstrate specific competencies or competence in skills. And so we're doing that analysis utilizing the simulation program, which the third scenario, if you're not familiar with it, actually has a skills assessment. So it'll be interesting in future analysis to look at perceptions of competence compared to demonstrating competence by being able to demonstrate skill. So that's kind of where we're headed. But it's nice to see we were able to demonstrate competence or perceptions of competence over time. You could advance to the next slide. So as I mentioned, or I may have mentioned earlier, confidence and readiness. You know, these are the two things when I tend to be in venues where there are evaluators a lot, and they'll say if you can't measure everything and you really need to reduce the learner burden and measuring outcomes, focus on confidence and readiness, really speaking to self-efficacy, and that being one of the stronger predictors of future behavior. So we tend to place a little bit more, I guess, hope and confidence that we're going to see and demonstrate improvements in one's sense of confidence to actually deliver adolescent screening and brief intervention, and their readiness, that preparedness, willing to take action. And in this particular track, we did demonstrate improvements and increases in confidence and readiness, with readiness probably showing the most difference. And if you think about the readiness ruler or importance ruler or confidence ruler from 0 to 10 and moving learners from a 6.2 to a 7, I'd say is practically it's meaningful. And readiness as well, moving people somewhere in the middle of readiness from a 5.2 to 7.2. So that's clearly something that we're glad to see. We want to replicate this and these analysis and this kind of evaluation. I can tell you that we have run another evaluation. We propose to do a randomized field test trial, and those analyses are being done, and actually most of those are done. We're writing those up for publication. We actually did replicate the finding with confidence and readiness, showing in that particular track that the simulation program alone, so this without the use of instructor toolkit materials and other types of learning aids over the course of a period of time in a semester, just the simulation alone actually showed significant improvements in attitudes, competence, confidence, and readiness. So we're looking forward to sharing that with you in a publication. You could advance to the next slide. So this gives you a sense of the reach. One of the things that in our project we have really wanted to do, and working with the Conrad Hilton Foundation, is reach, dissemination. We need to reach more schools, more educators, preceptors, field instructors. How do we reach them? And really developing a network, a robust network. And this graphic, this map, gives you a sense of where our reach was when we analyzed this data maybe 30 days ago. I think we probably have touched even more. We've over 800 organizations, individuals, most of them being unique, have reached out to us to engage us in receiving the curriculum materials, training materials for practitioners in the current workforce, and academic programs looking to implement the materials in their programs. We have been able, I'm sure I've seen many of you at conferences and exhibits this year. We have been out there really trying from coast to coast, reach as many academic programs and those field sites where those community organizations where students are being received and we're trying to train up the workforce. So we've really been out there trying to disseminate. And so I hope if you aren't familiar, you will request your own copy of the materials. You'll share it with others, because one of the things that we're learning is, all the government funding and support around, focusing on adolescents, screening and brief intervention, and disseminating materials, resources is incredible. And without that funding, it's hard to move a mountain or a boulder up a hill. But the Conrad Hilton Foundation has really just energized this whole effort to disseminate across the United States, and we have to do it together. And so that's what you're seeing when we describe the implementation tracks here. We're giving you a sense sort of right now of the programs that are involved in the evaluations, the various evaluations that we have. But we have certainly touched more than just the number of programs who've participated in those particular tracks. And we look forward to working with you and your colleagues in 2018 to continue, because I really think we are turning a corner with disseminating education and training and academic programs. The other thing I would encourage you to do is, if you're not familiar with sbirt.webs.com, is to go to the website and check out the resources. We've cleared the sharing of those resources with those who either created them or they're in the public domain, and they're all available to you. And again, like Hildy had mentioned, you can request electronic copies of our Learner's Guide, which is, the current version is 2.0. We release 3.0 very shortly, but go ahead and request 2.0. We have a complete companion slide deck, as Hildy mentioned. You electronically create that, request that, and we will send that to you. The sample measures, the measures I've been talking about for evaluation, those are there. You can request copies of those, and I will personally send those to you. And I'm glad to talk with you about any of the materials. We look forward to your feedback. But we really want you to share the information and engage your colleagues so we can continue to turn this corner and make an impact across the U.S. The other thing that we are looking forward to doing, in addition to the presentations and the posters and the oral presentations, is getting out some of the results in the scientific literature. And if you are doing your own evaluations, one of the things the literature desperately needs is, I think, is more around evaluation of education and learning and training, and what kind of outcomes are we demonstrating, both from a process perspective and learner outcomes, where we've been using the consolidated framework for implementation research to analyze the massive amount of qualitative data around implementation. And we've been partnering with IRETA, who was SAMHSA's National SBIRT ATTC, to look at that data, and we look forward to releasing the findings and results from all of our evaluations in some way, and I hope that you all will too. And last but not least, I would say that one of the things I've really, from this project that has been I've really enjoyed seeing, is the student engagement in this, not just the educators and instructors, but the student engagement in the classroom-based training, but also in the simulation training, when they don't want to complete pre-post surveys and they don't want to necessarily do homework assignments. We get strong engagement in the simulation as a training and educational tool, and we have been able to really engage people all the way through completion and taking skills assessment, evaluation. So I'm really thrilled about that. Our next steps are really to look at how are people performing. And one of the recent analysis I just did, after receiving all the training, the skills assessment showed, and did as a post-test only measure, that more than 80% had scored 80 or above. And so that's just one. Another evaluation we did showed that 97% received a score of 80 or more, and as a post-test measure. So again, I just thank all of you. I know some of you have been participating with us, so I appreciate your engagement. I appreciate you sharing. We look forward to working with you to do more evaluation and to have more programs like Laurel's be able to utilize this and evaluate and find how is it working in their own programs. So I will stop there, and let's go to the next slide. I'll turn it over.
Thank you so much, Tracy. Thank you, Laurel Hitchcock. Thank you, Tracy McPherson. Thank you, Hildy Cohen, for these really, really engaging presentations. It's wonderful to see the results of these evaluations that you have been conducting around the implementation of the curriculum and the simulation. We want to thank also the Hilton Foundation for supporting this program and enabling us to train thousands of health professionals, current and future health professionals around the country to have these important conversations about substance use with adolescents at every opportunity. we have some time for questions and answers. Some of you have submitted questions through the webinar system. So if you haven't done so yet, on the right side of your screen, you should see a small window that will enable you to ask us any question you wish. So please feel free to go ahead. So our first question goes back to something that Laurel mentioned in her slides. The question is, can you touch base on the mandated through statutes point again about the insurance? So I think this refers to your point, Laurel, that SBIRT can be mandated through statutes. Could you speak a little more about what those mandates might be, both in terms of education and in terms of implementation in the field?
Absolutely. And actually, I'm going to turn this over to Tracy, who knows a lot more and can speak to this better.
Well, there are a couple different things I would say about mandates. You know, the EPSTD, the early preventative, you know, EPST for children. That's where that it's expected that for the well child visits that there is screening that is done. I also know on a practical level that's very challenging and it may not actually often get done. But certainly that is one place in a lot of the arenas that I've been in lately with health plans who serve, who are serving communities that really do look at the EPSD DT visits. That's really the place where I'm seeing more of a conversation in terms of adolescents. The other thing in terms of not a mandate, but it's a strong recommendation or guideline, obviously, is around the professional association strong recommendations around screening and brief intervention for young people. And it's not a U.S. Preventative Services Task Force recommended guideline yet, and they are looking for literature, actually. So if you have literature and findings from your projects to share, there are scientists looking at this literature and are looking for more evidence to support it. We're not there yet for them to endorse it. But the professional associations and other agencies, your federal agencies, have put out very strong guidance and endorsements. They're not mandates yet for that providers have to do it necessarily. So that's where I would say we sort of are with that with adolescents. The other place in terms of opportunities for mandates, and again, we're not there yet, but I think we're making progress, is around requiring programs, academic programs, schools of social work, nursing, psychology, counseling. I think we've seen a lot more movement in nursing and social work around this, and a lot more conversation about implementing educational standards that speak directly to integrating substance education and screening and brief intervention related education into programs. It's not currently an educational standard required by some of the professional associations, but I can tell you right now there are associations like AACN and CSWE who are looking at their educational standards and have working committees addressing this, and how does screening and brief intervention education map to those educational standards. I hope at some point we will get to the point where that is a mandate for education.
Thank you so much. And there's a related question actually around SBIRT being covered. The question is, SBIRT is currently being covered by the Affordable Care Act. There are efforts to repeal the Affordable Care Act, so should we expect SBIRT to continue to be covered for practitioners?
Well, if I had a magic all or has some inside tracks to. I don't know. I really don't know. I mean, I'm in circles where there are folks who know a lot more about the various inner workings of that. But certainly, I don't know. I don't know if anybody knows that. I don't know that I could answer that in an informed way.
Yeah. But certainly, our hope is that with the continued move towards patient-centered care and the integration of primary and behavioral health care, my expectation would be that these will continue to be covered and that the reimbursement codes from Medicaid, Medicare, and private insurance would continue to stay in place.
Yeah, I think many of us are very hopeful. I don't think we know. I think one of the things that I am seeing that I hope is a sign of hope is people are talking about the codes. They're trying to figure out how to utilize the codes. I mean, the codes have been out there, but there are so many challenges around this. And I'm listening to health plans who say, "Help me figure out how to use the codes." And those are conversations I wasn't having, a couple of years ago. So there's more conversation about that and defining the codes or redefining the codes. How does that work? How is it defined for a particular setting in a way that I guess I'm encouraged, but I don't know. I guess I'm hopeful.
As we all are. We have another question about the evaluation aspect of the project. A participant asked whether we are also measuring confidence in the RT part of SBIRT or the referral to treatment. So is that part of the confidence measure?
Yes. So we have several measures that we worked with our steering committee to develop, and we can share some of those with you. And I will say that there are other programs who are not participating in track who have adapted them slightly because you want to make sure that your measures align with what you're teaching or training on. And in some programs, they don't spend a lot of time at all on RT. It's a choice, probably because of time and resources, and so they may not utilize those items. Other programs may decide to utilize those items. But certainly, I think it's important to measure without creating burden on the learner, and the person, completing these surveys is to try to get at that all of those things: confidence, competence, readiness. I think there are attitudes around referral as well. And so I would encourage those tools around every aspect of screening, brief intervention, referral to treatment, motivational interviewing. They're different skills, they're different elements, and I think it's important to measure those, but I know that folks do pick and choose what they want to measure. So I would encourage people to look at it. It's the weakest link, and I think that people may not have a lot of confidence for a lot of reasons. But we need to be focusing and building that confidence, I think, in our programs, not just drop it. I think it's a missed opportunity.
Thank you, Tracy. Our next, actually, there's a follow-up question from somebody who would be interested to look at the evaluation tools. How might we look at the evaluation tools to adapt? I suppose, Tracy, I can put you in touch with this participant, or the participant, feel free to reach out to Tracy McPherson. You have her email address on the screen, so feel free to reach out to any of the presenters if you have a question.
Yeah, in fact, when you go to sbirt.webs.com/curriculum, that's the curriculum tab, and you request a copy, there's an online form. It says request a copy of the sample measures. You can that up. You put your information in. It sends me an email. I'll respond to it, and then you're welcome to ask whatever questions or set up a call, and we can talk about them. So that's probably the one easy way to do it.
Great. Thank you, Tracy. So a question around, a really interesting question actually, around patient outcomes. And the question is, how are you engaging adolescents in recovery from SUD or OUD, substance use disorders or opioid use disorders, in assessing the actual skill and effectiveness of those who have received our training in using SBIRT with real adolescents? In other words, how can we engage adolescents in recovery, or those who have received SBIRT services to assess the effectiveness of the training for those who provided those services? What do you think?
Sure, no, it's an excellent question, and one I certainly hope to have the opportunity to address. The scope of our project, as you know, we've shared with you, has been that workforce development and getting into communities and training up, you know, both the students who are going to go into those communities and elsewhere, as well as those who supervise them, the in-field instructors, the preceptors, and hoping that we, you know, motivate and engage those individuals to spread it within their community organizations. Interestingly, we still have that experience where you have the field instructor or preceptor who is really excited and wants to do it in their organization, and they talk to people at the site and they say, I have no idea what SBIRT is. And so you're starting at ground zero. So it's there are a lot of communities still having conversations about what is it, what do we do, how do we do it, how do we get trained to do it. So in some of these there isn't yet, but there's potential to look at the patient outcomes. There are other participating programs that do have a lot going on in their communities. Many of them may be those who've had SAMHSA or HRSA funding over the years, may not now, but you know, have before. And there's a lot going on in that state or that community. Or these are leaders in this field of research and practice. And so one of the things that I'm looking for the opportunity for, and we've been having conversations with our Learning Collaborative members about this, is how can we look at communities that have low resources, high needs, or academic programs, low resources, high needs, community organizations that would be interested in working with us. So we're working with the academic programs in those communities. We're working with the practitioners in those communities who provide supervision and training, who provide services in those community organizations that serve adolescents. How do we identify those and work with them to then take our work to the next stage, which is to look at, by training the students, the future workforce, by training those existing workforce, by training those organizations to build capacity. There's also, it's not just training, it's capacity building, it's organizational consultation. How do you help an organization serve adolescents in that way? And can we identify some opportunities and communities to work with where we actually can look at the adolescent patient outcomes? Do things change over time? Very, very complex process, clearly, but it's the direction that I think we have an opportunity to move in our project, and certainly something we look forward to exploring more, because we do want to know, does it make a difference in youth?
Thank you, Tracy. And we just have time for one final question. The question is, how are you engaging seasoned practitioners in the field to use this use this as a continuing education tool? And do they find the simulation as relevant and engaging as students? So I'll give a partial answer and then turn it over to Tracy. But this simulation is currently being used in a continuing education capacity. We have professional associations as well as health plans and state and federal agencies that have licensed these tools to disseminate them to a variety of settings. And yes, we do find very high engagement with the simulation, very high uptake, and very high engagement with the content, high ratings of the content. So I think the tool is just as applicable to practicing professionals as it is for students in university settings. Tracy or Laurel, would you like to say a few words about that?
Real quickly, this is Laurel. I'll just say that we have been engaging all of our field instructors in the social work program, and we've been engaging as well when our nursing folks came on board, the nursing preceptors, offering this training to them and providing continuing education, which has been a benefit for the through the Hilton project. Additionally, I've been speaking across our campus about this and going out and talking to different agencies about SBIRT and how to incorporate that.
Great, and professionals also receive continuing education credits through the simulation, so it's really designed to be applicable to them.
Yeah, and I would
Laurel, Tracy. Oh, sorry, Tracy, please go ahead.
Just wanted to say for the practitioners, we have taken this learner's guide in a simulation and have taken it on the road with help of expert trainers and have trained focus on practitioners. So this could easily, and already is, being utilized with practitioners in the same way it can be utilized with students. So the simulation and the curriculum, you could change it to training guide, and it's easily implemented in that way, and we're doing it. So I hope people will see it as not just an instructor toolkit for in the academic environment, but also it's a workforce training tool is also what it is.
Absolutely. And with that, I would like to thank all of our participants. Thank you to the hundreds of people who joined us today. This was a really wonderful conversation. We're very happy to have you all. Thank you, Laurel, thank you, Tracy, and thank you, Hildy, for your presentation. And please be on the lookout for future webinars with us. Thank you again. Have a great day.
Thank you.